السلام عليكم طلبة الأعزاء. محاضرتنا اليوم عن ال Physical Examination of the Newborn Infant with the entitled Objectives. By definition, to start with, we have what is called the neonatal period, which is the period in between the 28th week of gestation until the 7th day of life, while the neonatal period is the period in between the first day of life until the 28th day of life, the first 4 weeks of life, while infancy is the first year of life. The initial examination of the newborn is essential and to be performed as soon as baby is delivered, which has the task of detecting any abnormalities and to detect and establish a baseline for subsequent examinations. We check the vital signs. We check the following things, including the temperature, pulse, respiratory rate, color, type of respiration, tone, activity, and level of consciousness. Congenital anomalies are present in 3 to 5% of infants, and for afterwards, a second examination should be conducted within the next 24 hours before discharge of the baby. Physical examination is one of the things to be checked, including the activity of the baby, movements, whether he is crying, whether he is calm, so calm, and any abnormal movements across the ankles and the jaws are called myoclonus, which are a normal finding in newborns. Edema should be checked for, which could be encountered in prematurity, hypoproteinemias, secondary to severe hemolysis, and in congenital nephrosis. This is for the generalized, while edema may be confined to one or more extremities in females, especially in those of Turner syndrome. The skin could be irregularly discolored due to vasomotor instability and attains what is called the marbling of the skin. There might be acrocyanosis, skin mottlings. There could be what is called harlequin color change of the baby, which is a unilateral red to and pale house of the baby from up to down. The skin is usually covered with vernix caseosa, which is a creamy material and disappears spontaneously within a few days. Transient macular hemangiomas might be encountered over the neck and the eyelids and is called stork bite hemangioma. Mongolian spots are blue well demarcated areas of hyperpigmented skins, macules over the back and the buttocks, and it might be present as long as 1 year of life or even more. The skin of premature babies is usually red, delicate, and it might be covered with lanuga hair. Tufts of hair over the back, it might indicate spina bifida, while yellowish to brownish discoloration of the skin, it might indicate meconium, staining of the amniotic fluid and stained skin. These are photos of the Mongolian spots on the up left and confined edema to the legs and the hands in a female baby with Turner syndrome. And in the lower left photo, there is a vernix caseosa covering the skin of the neonate. Neonates should have their skull circumference be measured, and any abnormal molding of the skull due to prolonged engagement of the head could be monitored. Caesarean section babies are usually having the rounded skull shape, and the suture lines should be checked for their size, and the fontanelles also should be checked. Premature fusion of sutures is called cranial synostosis. The anterior fontanelle usually measures in between 20 to millimeters plus minus 10 millimeters. That's to say, in between 1 to 3 centimeters. The posterior fontanelle might be felt in early life, and white fontanelles might be associated with achondroplasias, hydrocephaly, prematurities, trisomies, including trisomy 21, which is the Down, trisomy 13, which is the Patou syndrome, or trisomy 18 is the Edwards syndrome, or it could be encountered in vitamin D deficiency rickets. Persistently small fontanelles is present in cases of microcephaly and craniosynostosis or congenital hyperthyroidism. Checking for big fontanelles and hydrocephaly through transillumination of the skull through the fontanelle. Asymmetric skull is called plagiocephaly due to molding of the head and abnormal positioning of the head in the uterus, or the presence of uterine anomalies including fibroids and so on, or multiple pregnancies. The face of the newborn should be checked for abnormal facies, dysmorphism, the ears setting, high or low set ears, usually low set ears in some syndromes, the slanting of the eyes, the presence of microphthalmias, an asymmetry, or there might be facial nerve palsy, the seventh cranial nerve, which might be encountered. The eyes should be checked for slanting of eyes, the conjunctiva checked for hemorrhages or associated with deliveries, especially in assisted delivery. Regarding the cornea, it should be not more than 1 centimeter in diameter. Otherwise, it is related to congenital glaucoma. The iris also should be checked for the red reflex in every newborn baby, as if there is no red reflex, it's called leukocoria, or what's called the cat's eye. It is related to congenital cataract. It's called the white pupillary reflex. It might be related to congenital cataract or retinoblastomas. The ears also should be checked for the alignment, for the up or low set ears, or the presence of preauricular skin tag. Newborns might have obstructed nose due to the presence of the mucus, which is very common findings. Otherwise, there might be anatomic obstruction of the nasal passages, unilateral or bilateral, and especially in the bilateral, what is called the choanal atresia, it might result in respiratory distress. So the baby gets blue whenever he is calm and closing his mouth. Whenever he cries, this cyanosis disappears. The mouth of the baby might have natal teeth, and which is harmless, and it sheds usually before the dishes with teeth. The palate should be checked for the presence of Epstein pearls, which are seen in the photo below left, and the natal teeth are present on the right side of this photo. The mouth might have retention cysts seen on the gums, and they disappear spontaneously within weeks of life. The frenulum might be so short that it traps the tongue and makes what's called the tongue tie, which has got nothing to do with speech, delayed speech, and it might interfere with nursing of the baby that's feeding him. So a frenutomy might be conducted. The cheeks have full uh, appearance due to the presence of suckling fat pads, and the neck of the baby is usually short, and there might be masses in the neck, including the goiter, the cystic hygromas, teratomas, hemangiomas, or sternomastoid tumor. The sternomastoid muscle might be affected in traumatic delivery with the resultant of bleeding in the muscle and causing a mass in the sternomastoid muscle, and which appears on shifting the head on a side. The neck of the baby should be checked for redundant skin or what is called webbing. Its presence in a female neonate it might suggest um, Turner syndrome or intrauterine lymphodemas. The clavicles also should be palpated for fractures, and if they are tender enough, it might indicate the presence of fracture, especially in obstructed labors. The chest of the baby checked for breast hypertrophy, which is common, and the milk may be present, which is called witch milk. Otherwise, mastitis or breast abscess might develop, especially after wrongly manipulating the breast tissue. This is a photo of webbing of the neck with a low posterior hairline and might indicate Turner syndrome, while the upright photo has the finding of sternomastoid tumor or bleeding into the sternomastoid muscle with the resultant torticollis later on in life if not treated well. The lower photo shows the gynecomastias, which is a normal finding in babies, which is related to maternal hormone effects on the baby, including a male or a female. Otherwise, if it is red, it might and hot, it might indicate infection or inflammation, including mastitis. The respiratory rate is counted over full 1 minute and ranges in between 30 to 40 per minute, and it might be up to 60. The rate, which is constantly above 60, it might indicate a pulmonary, cardiac, or metabolic disease, or what's called acidosis. Premature infants may have what is called the periodic breathing pattern or the Chine-Stokes breathing rhythm, and the respiration is mainly diaphragmatic due to the use of diaphragmatic muscle and assisted by intercostal muscles. Weak cry or grunting during expiration, it manifests a cardiopulmonary disease. Flaring of ANISI and prominent intercostal recessions, retractions, it will indicate respiratory distress, as these babies, they don't use their intercostal muscles actively unless there is respiratory distress. The location of the heart uh, is usually levocardia in normal positions, or it could be abnormally right-sided heart, what is called the dextrocardias. Listening for the heartbeats, the presence of extra murmurs should be encountered. The pulse usually varies in between 90 to 180 beats per minute. On average, it is 110 to 140 beats per minute at rest. And the pulse should be palpated on both the upper and the lower extremities to detect any presence of coarctation of aorta. Regarding abdominal examination, the liver is usually palpable 2 centimeters below the costal margin, and the tip of the spleen might be felt also. The gases in the bowel reaches the rectum by the 24 hours of life, while at birth they are absent because there is no air in the bowel. And its delay, it might indicate obstructions. There might be cystic masses in the abdomen, which are might be the hydronephrosis, multicystic dysplastic kidneys, adrenal hemorrhage, intestinal duplications, ovarian cysts, omental cyst, or pancreatic cyst. Solid masses in the abdomen might be encountered during initial examination, and these include the neuroblastomas, congenital nephromas, hepatoblastomas, and teratomas. Abdominal distension at birth could be encountered in early life, which might be related to obstruction or perforation of the bowel, while later distension it is related to lower bowel obstruction, sepsis, and peritonitis. The presence of what is called the scaphoid abdomen, as if it is an empty abdomen. It is related to diaphragmatic hernia and should be noticed. Abdominal wall defects also might be present in the form of omphalocele. This is a photo of a scaphoid abdomen on the upper left and showing the respiratory distress in the form of intercostal recessions that prominent ribs while the baby is having respiratory effort. He is in respiratory distress because the bowel is in the chest, as it is seen in the lower X-ray, erect X-ray. And we see the bowel on the left side, usually on the left side, displacing the heart and causing respiratory embarrassment. Omphalocele might be big enough, just like the upper right, and we might find part of the abdominal wall lost, and the bowel or even the heart is displaced outside. The term omphalitis, it is related to acute inflammation of the periumbilical tissue, which may extend to the abdominal wall, peritoneum, or umbilical vessels, causing sepsis and later on portal hypertension. The umbilical cord should have two arteries and one vein. In the presence of one artery, it might indicate an occult renal anomaly. Regarding the genitalia, the maternal hormones might pass into the baby through the umbilical cord and cause enlargement or prominence of the female genitalia and the presence of non-purulent discharge in the females, creamy in color, and might cause enlargement and of the breast tissue and the presence of milk even in both sexes. So these might occur, and these are part of the normal variation in neonates. And they usually require only observation and nothing else. If the hymen is imperforated, it would cause what is called the hydrometrocorpus and making the hymen bulge through the vagina, as it is seen in the lower photo. Black male infants have dark discoloration of the scrotum, and usually the color of the scrotum indicates the future color of the baby. The prepuce of the newborn is usually tightly adherent to the glands and should not be retracted. The presence of hypospadias or severe hypospadias, it might be related to congenital adrenal hyperplasia, and it might indicate a masculinized female or virilized female with enlarged clitoris and the presence of the urethral opening in this big clitoris, which might be mistaken for a male. And it is part of the ambiguous genitalia problems. The urine is usually passed within the first day of life in 95% of cases. Most term babies, in 99% of them, and in 95% of the preterms, they pass the meconium within the first 2 days of life. The presence of imperforated anus should be looked for, and so that every newborn should be checked for this condition by insertion of a rectal tube or simply a thermometer, and if necessary, X-ray should be done. The passage of meconium doesn't rule out imperforated anus if a rectovaginal fistula is present. These photos show the imperforated anus with a flat anal region, and this is the X-ray of upside down of this condition and applying a coin over the buttocks, and we see there is no gas bubbles and a bit of no gas bubbles distance in between the end of the these bubbles in the large bubble and this coin indicates a high obstruction, which it surely needs surgery. And this is an anal dimple, which is a finding which might be mistaken for sinus. It is called the sacrococcygeal dimple. Extremities are checked for position, activity spontaneously, and posture to detect any occult anomalies or fracture or injuries, nerve injuries to them. The hands of the feet should be checked for the number of the digits, as there might be what is called polydactyly or due to multiple toes, and or could be syndactyly, fusion of the toes, and any abnormal dermatoglyphic patterns seen in hands, which might indicate a presence of semicrease, which is present in 70% of down babies. The hips should be checked for DDH through the Barlow test and followed by the ortolani if necessary. Low-risk infants' routine delivery care includes fair positioning of the baby on a flat table under a warmer and cleaning his oral cavity and mouth and the pharynx and the nose with a mucus extractor or a soft catheter to take out any mucus, remnants of blood, or amniotic debris. While vigorous whipping of the palate and the pharynx might cause abrasions with subsequent thrush or ulcers or even maxillary osteomyelitis might develop. Stomachs of newborns by cesarean sections needs to be emptied with a nasogastric tube, while those of vaginal delivery needs not, as during delivery they usually expel their amniotic content of the stomach. And healthy deliveries are given to their mothers immediately for proper bonding and nursing. Scoring of the newborn is done through the use of the APGAR score, which is a practical, systematic assessment of the newborn, done immediately within the first minute of life after birth to help identify those who are requiring resuscitation and to predict survival in the neonatal period. The 1 minute APGAR score is usually signals to the need of immediate resuscitation, while that APGAR score of 5 or 10 or 15 or 20 minutes after delivery indicates the probability of successful resuscitation of this infant. The APGAR score is not designed to predict the neurological outcome, as many those of CPs, babies, or cerebral palsy, they have a normal score. While the APGAR score at 5 minutes with low umbilical artery blood pH, it might predict neonatal death, early one, and the low score may be due to a number of factors, including drugs given to the mother before delivery. This is a diagram of the APGAR score with its 5 elements or parameters, and it is checked at 1 minute of life and at 5 minutes of life usually, and it helps us to indicate which neonate is in need of help of resuscitation. These parameters include the heart rate. Is given 0 if there is no heart rate, or it is below 100 is given 1, or 2 if it is over 100. Regarding the respiratory effort, no respiration 0, he is given 1 score for the slow irregular respirations. If he's having good cry, he is giving 2. The muscle tone, either he is limp is given 0, some flexion given 1, or active motion given 2. Regarding response of the neonate to the catheter in his nostril, it is either 0 or there is no response, or it is just grimacing. He is given 1 and given 2 in the presence of cough and sneezing after installation of this catheter. The color of the baby, if he is blue all over, blue to pale, he is given 0. And if he is blue by extremities and pink by body, he is given 1. If he is completely pink, he is given 2. Here is an example of a newborn with APGAR score at 1 minute, indicating a heart rate of over 100, respiratory effort of slow, irregular in type. The muscle tone shows some flexion of the extremities. Response to catheter shows grimacing in the face. And the color of the baby is pink by body and blue extremities. So collectively, he is giving the score of 6. In the presence of 6 over 10 APGAR score at 1 minute, he will be in need of ambu bag ventilation. And this diagram shows an example of checking the APGAR score at 1 minute and 5 minutes of life. At 1 minute of life, he is showing a heart rate of over 100, a respiratory effort which was slow, and a muscle tone having some flexion. The response to catheter, it was a grimacing of the face. The color of the baby was pink body and blue extremities, so collectively it was 6/10. And so he is in need of ample bag ventilation. At 5 minutes, he got the Apgar score of 10/10, which is very good. Regarding maintenance of body heat, the infant service area is very large in regard to his body weight. It is 3 times that of an adult. And under usual delivery room circumstances, the temperature in this room is in between 20 to 25 degrees centigrades, and the skin of the baby would lose a temperature of zero point 0.3 degrees centigrade per minute, and the core body temperature or the deep body temperature decreases by 0.1 degrees centigrade per minute. So we should conserve the baby core body temperature, and the room temperature should be good enough to prevent this loss of heat. The heat loss occurs through either convection by the cooler surrounding air, or could be by conduction to the cooler materials beside, or by heat radiation to the nearby cooler solid objects, or by evaporation from the moist skin. Infants exposed to cold develop metabolic acidosis, hypoxemia, hypoglycemias, and increased renal excretion of water and solutes. They increase their heat production with increasing the metabolic rate and oxygen consumption by releasing the norepinephrine, which results in non-shivering thermogenesis through the oxidation of fat, and there might be some increased muscle activity. In the presence of hypoxemia or hypoglycemia, these infants cannot increase their oxygen consumption, so their central body temperature lowers down. And to reduce the heat loss, it is desirable to ensure these infants are dried up and wrapped in blankets or placed under a radiant warmer. Kangaroo mother positioning and care through skin to skin contact directly would result in a fair thermal control of these newborns. This is a photo of the kangaroo positioning of the newborn baby, and we should maintain a humidity relatively a bit high, in between 40 to 60%, which aids the stabilizing the body temperature by preventing drying of the airways and the respiratory passages. The skin and the cord should be cleansed after delivery with warm water and non-medicated soap solutions and rinsed thoroughly with water. To reduce the colonization of the Staph aureus, we might use the daily treatment of the umbilical stump with a triple dye or bacitracin, followed by twice daily alcohol swabbing until the cord falls off. Alternatively, chlorhexidine might be used for washing, or in rare occasions, in the presence of epidemics of Staph aureus, we might use the hexachlorophene bath, yet it is not used repetitively as it is neurotoxic to the newborns, as it is absorbed through the skin. Nursery personnel should use the chlorhexidine for routine hand washing, hand to elbow washing for 2 minutes for the initial entrance of the nursery, and on subsequent washing it should be in between 15 to 30 seconds. Is essential for the staff and visitors hand wash. The eyes of the newborn should be protected against gonococcal infection by the installation of 1% silver nitrate drops Alternatively, we might use the erythromycin or tetracycline ophthalmic ointments. Every newborn is injected with zero point 0.5 to 1 milligram of soluble vitamin K1 to prevent deficiency of vitamin K dependent factors, which might result later on hemorrhage. Larger doses of vitamin K might result in hyperbilirubinemia. Every newborn should have a screening test to cover genetic, metabolic, hematologic, or endocrine disease. And these specific tests vary according to the country. These tests might include a heel puncture and a blood sample on a filter paper and sent for primary screening of many medical problems, including the hypothyroidism, the phenylketonuria, galactosemia, maple syrup urine disease, homocystinuria, adrenal hyperplasias, hemoglobinopathies, cystic fibrosis, tyrosinemia, and other genetic diseases. Hearing test in the form of the ABR, which is the auditory brainstem response screening test, is done for every newborn, as hearing loss might occur in 5 to 1,000 live birth, and severe loss, it is present in 2 per 1,000 live birth. So it is recommended to detect the hearing loss and for early intervention. Babies also checked for pulse oximetry to detect cyanotic congenital heart diseases and for hyperbilirubinemias through the transcutaneous bilirubin levels checkup, and checked clinically in every neonate for congenital hip dysplasias by the Ortolani and the Barlow test. Yet no routine ultrasound is done unless we are in the suspicion of DDH. This is a photo of the pulse oximetry on the right side, while on the left side we check for the Barlow test on the left, and later on we try to relocate the displaced hips by the Ortolani test if it is positive for the Barlow test. Early parent-infant bonding is important for healthy psychological and physiological upgrowth of the baby, and it is reinforced by the emotional support of the loving family. Eye-to-eye contact is important, as it is important in stimulating the loving feelings of the parents to their babies. Breastfeeding in the immediate postpartum life is important. It should be started within half an hour and last for 5 minutes on each breast. It sounds reasonable, and it could be either on need or a scheduled one. There are drugs which are contraindicated during breastfeeding, and these include the antimetabolites, immunosuppressants, methimazole, which is an anti-thyroid drug, amphetamines, iodides, and radiopharmaceuticals. While there are medical conditions which contraindicates breastfeeding, including HIV infection of the mother in the developed countries, the CMV infection of the mother, active tuberculosis of the mother until she is treated for and become non-infectious, hepatitis B virus infection. In this case of the mother, should the baby receive the hepatitis B immunoglobulin soon after delivery and hepatitis B vaccine if the mother is hepatitis B surface antigen positive. Another illness is the hepatitis C infection, the varicella zoster and herpes simplex infection, and the chemotherapy and radiopharmaceuticals.